Hello, and welcome to the Prescribing the Future podcast, where we explore how technology is transforming the way care is delivered. I'm your host, Dr. Jean-Luc Neptune, clinical commercial leader at Commure. And today I'm joined by Dr. Darin Brannan, Chief Clinical Innovation Officer at Bethany Children's Health Center in Bethany, Oklahoma. Dr. Brannan, welcome. And if you'd like, why don't you do a little quick introduction of yourself and who you are and what do you do?
Um, Glad to be here. I'm Darin Brannan. I'm a pediatrician by training, a clinical informaticist. I've been at Bethany Children's Health Center for well over 27 years, caring for kids with complex medical illnesses. And current roles include still involved in clinical care, as well as on the informatics team and our clinical innovation as well.
Sounds good. And can you tell us a little bit more about Bethany's in terms of, and is it Bethany Children's or do you guys call it Bethany's as well?
Bethany Children's,
Okay.
yeah, Bethany, because the city is called Bethany.
Oh,
So,
right.
Bethany Children's Health Center is a 160 bed hospital that is subacute, pediatric, rehab, as well as long term care. Our average length of stay is about 2 years. We have within our population, greater than 50% of our kids are ventilator dependent. They're dependent on technology, which does kind of mean that there is a lot of information that's being generated that we need to utilize as best as possible to support our clinical staff.
Understood. And for people who may not be familiar with clinical care, I mean, to have a 2 year length of stay, that is a long time to be in the hospital, and that is just a tremendous amount of information to be managed every day. I hadn't heard this stat before, but 50% of your kids are vent dependent. I mean, that is a very high intensity of care that is so different from, let's say, the ambulatory care that most people are familiar with. So you're doing challenging work there, and again, I think very important work at the same time.
Yeah.
All right, great. So I think one of the things that I wanted to talk about is the interesting work that you're doing with technology. As you mentioned, technology is important, plays an important role, and you've been doing a lot of work with ambient scribing technology. You've been an important partner for us in that, and I just wanted you to maybe just talk a little bit about your experience. What were your goals as you were thinking about this, before you even started using the ambient technology? What was your goal? What were you trying to accomplish, and how has that evolved over time?
Yeah. So that's an excellent question. And since actually before the pandemic, we had been on a quest to measure and address provider burnout. In 2024, we completed our second provider evaluation. And while there was some general movement towards reduction of the level of stress, there was no change in the time it was taking them to document. And so from either general pediatrics or complex pediatric providers or our specialty providers, the consensus was that it was taking them about 2 to 4 hours a day to complete their documentation. And an obvious side effect of this was that there were delays in referrals, delays in prior auths, delays in billing. And as you can imagine, there was some potential downstream workflow impact, as well as just simply the continuity of care that was somewhat being impacted by the lack of getting those documents completed and signed off in a reasonable manner. I would say in November of 23 was the beginning of our journey where we kind of ratified internally our AI acceptable use policy. By July of 24, this was a full year before we even tinkered with ambient AI. We had our first official and unofficial contact with ambient AI product. And in February of 25, we initiated two separate pilots for ambient listening products. And in July of last year, we went live with Ambient AI, not only for our outpatient and specialty outpatient providers, but also for our inpatient hospitalists and inpatient consultants that were even coming from other facilities to see our kids.
Got it. Interesting. And it's funny that you mentioned, if I interpreted what you said correctly, the initial frame for addressing or approaching ambient was around burnout, right? So that's an interesting thing, because again, I think people are starting to realize that taking care of your providers, taking care of the people who take other people is very important. You and I probably, when we were training, that wasn't so relevant, but it's interesting to hear that that's what you led with. But then discovered, like, wow, there are all these not discovered, but also understood that there were many other issues that were being impacted by documentation and the time it was taking. And it's incredible to think 2 to 4 hours a day per provider in documentation. Wow.
Yeah.
All right. So, Darin, why don't we talk a little bit about how things have evolved? It's great to hear about, how you got to this point in terms of, what drove your decision to pursue an ambient solution. But help us understand how things evolved over time. You've had, from what I understand, more than 40 providers using the technology now, tens of thousands of notes, or 10,000 plus notes so far, and you're using the technology across a broad range of providers. So maybe talk a little bit about that and how that's evolved over time.
Okay. Well, even before we began our pilot, we had purposed in our mind that any discipline that required both data intensive and multi-pass documentation would be a target for ambient listening. And so the typical process for a clinician, whether you're a physical therapist or a pediatrician in the office, there's this exchange of information verbally, reading, and then you're typing into the record. And that is the principal drain for these 2 to 4 hours of post clinic day documentation. And so therefore, we determined that single pass documentation would be our principal objective for all disciplines. And therefore, that would mean that we would be using ambient listening for this. A very good example was a physical therapist that approached me about a month before Inspire, and had asked if she could use Ambient AI for her equipment clinic, very data intensive. And also of note is the platform is incredibly intuitive and user-friendly. So within the same day, she had already created her own template. No one had to support her. And the following day, she was already off out of the gate, creating her encounters as a single pass. And so that was, I think, a phenomenal statement of the ease of use of the platform. And the other thing too is that we've continued throughout the entire use of ambient AI to really look at non-traditional, even those where the patient is not engaged. So we can have providers who are creating log notes, providers who are doing chart review and prep, where they're just kind of reading through and dictating it, meeting notes, patient care teams. Those are just kind of some of the examples where it's been very useful.
Sounds good. And if from what I remember in our discussion, you also mentioned that there were some interesting ADA applications. So for providers with disabilities, again, I mentioned this to you before. I never think about physicians as having disabilities. We help people with disabilities, but I always forget that many of us in the profession are dealing with disabilities of one sort or another. So can you talk a little bit about how the technology has helped those people?
Yeah, and I think the interesting thing there is that within our mind, and even I am guilty of this. I'm expecting a disability to be something visible, which in fact isn't the case. 80+% of disabilities are invisible. And therefore, when we do look at supporting our staff, regardless of discipline, within their engagement with patients, we need to be able to provide the resources to them to be able to excel at what they do. And, while we do have some providers that are physically handicapped, we have some that may have some difficulty with hearing. Um, the notion is that being sensitive to their needs and supporting them with the technology as much as possible. We've used software to navigate verbally through the operating system and to transcribe their documents. But clearly, it's not as useful as Ambient AI is, simply because it's capable of formatting it into that template that then means there is little or no post-acquisition processing.
Got it. Interesting. And the other thing that I was interested in too is sort of the culture at Bethany Children's. The idea that that person that you mentioned who works in, I guess that's the DME group or the equipment group, the idea that she would approach you and say, "Hey, I'd like to try this." I think that says a lot about your culture. Can you talk about your culture? Because again, and what I'm saying in parentheses is, so many hospitals are physician driven. Everything is around the physicians and everybody is sort of secondary. And that's something that I hate about medicine. It's something that I hate about the hierarchy. But it sounds like you may have a different culture there that encourages people who may not be physicians to try new things and to be part of the innovation process.
Right, and from our ITGC, our IT Governance Council, and our AI committee, those are staffed by disciplines throughout our enterprise. Some are clinical, some are non, some are nurses, therapists, administrative, IT. So it's all about bringing the team together that is helping this patient excel through their clinical recovery or their journey. And so, really, any discipline that feels they would benefit from it has it. And that's really, I think, been if there is going to be a secret sauce, that it's all about supporting everyone to help the child.
Sounds good. And I'm a big believer in these organizations where you're trying to tackle innovation. It can't be top down. It's got to be everybody looking at the problems that they're trying to solve, regardless of their role within the organization, and then asking, finding the technology, hopefully not having to ask for permission, but being able to access the technology that they need because it's at their fingertips to try to solve problems. And it sounds like you're really doing that right now.
Yeah.
All right.
Well, and I would put in this little caveat. It helped that we began the process a year and a half before we really were considering the use of ambient listening. And we already had the foundation for looking at the use of AI within our facility. We already had the processes in place. So it made it very easy at that point. And there was no second guessing and there was no risk. Our legal counsel wasn't freaking out. We'd already had those conversations and deliberations before.
Sounds good. So it's almost like the innovation infrastructure that you created that made that possible. So that's great. So we were looking at some of your data, and I think basically 98% of notes now are being driven through the scribe, which is amazing. Within every organization, in my experience, you have the early adopters, and then you have your skeptics. And I'd be interested in how did you think about managing those two separate populations? Obviously, that's an artificial bimodal view of the world, but generally that's the way we think about people. How did you approach those two groups?
Well, and honestly, I will admit that there was no specific approach that we took with those detractors, if you will, versus the ones who were enthusiastic. But I will say that as these skeptics were observing the reduction in time needed for documentation by those who did embrace ambient listening, um, they too became intrigued, not only by the fact that they were spending less time, but also, oh, they were actually happier. They weren't as moody and testy. So I think that there was no overt approach to the detractor. And I will say that our most staunchest detractor at the beginning is now among our top 5 users. And they continue to provide very good input to the others within the clinic who themselves are maybe new to our practice and have yet to implement it. But it is also important to acknowledge that the new clinicians that are coming out of their training expect
Mm-hmm.
AI, expect to use technology. And so we found that it is a incredible incentive to recruiting very good candidates for our facility when we can actually say, oh yeah, we've been doing this for a year. Um,
Yeah. So, it's interesting and so fascinating. I've heard that from a number of C-suite executives now that when it comes to recruiting, junior faculty, that Ambient is like a non-starter. Like if you don't have Ambient, if you're not using it, we wouldn't consider an opportunity, no matter how much you paid us, no matter, what benefits you offer. Without Ambient, I'm not going there. So that's an interesting finding. And then the other interesting thing that I think you mentioned, and I've definitely seen this, is you can try to drive adoption from the top. You can try to force it down, but the number one driver of a change in your detractor population is seeing their colleagues benefiting, and exactly what you're saying. Like they're happier, they're less stressed out, they're able to do the job that they want to do, and it's great to hear that data point
yeah,
as well from you.
yeah,
All right. And one of the other interesting things that we saw in your data is that the length of these interactions has actually increased. So patient visit time has increased. And obviously, if you're viewing this from an administrator lens, that's like the last thing you want. You don't want the visit time to get longer. You want it to get shorter so that you can see more visits. So help me square that. Like how is that a good thing?
well, and I think the thing is that when we really start looking at the process of collecting information, now most of the clinicians are either using their laptop, with it, they're logged in, they're got their ambient AI session open, or their smart phone, but they're not looking at it. They're engaging fully with the patient and the parent. There is a lot more information being collected. Whereas if you were the clinician that's having to type all of this, you're going to try to be really succinct.
Mm-hmm.
Try to make it as short as possible. Just give me the facts, ma'am. Don't give me all of this information. But the interesting thing is within Ambient AI, the user can dial up or down the verbosity. And there is a tendency, with very, very few exceptions, to dial up the verbosity to allow there to be a more complete story being told by the parent or patient. And therefore, yes, these notes are getting longer, but also there's less documentation being done directly by the clinician. So even if the document itself is getting longer, we're not necessarily making their documentation time longer, because we still have this 2 to 4 hour positive that we're not spending every day in actually transcribing everything that we can recall into the record.
Got it. Interesting. And again, another thing that I've heard from many providers is that ability to listen, to now capture more information, to capture more diagnoses, to capture a more accurate picture of the patient.
Mm.
A question for you around billing. Do you find that has improved your billing? Has that improved, the revenue that you're able to capture for the work that you're doing?
Absolutely. While I don't have any specific metrics to share, there have been, I would say, four of our providers that are currently using Ambient AI, that it was very common that their notes would go more than a week, one in particular more than 2 weeks, before actually being completed and signed off. So now what we're seeing is the vast majority of these documents are getting signed off the same day of the encounter. And so what that means is that those referrals are being placed that day. The prior auths are being processed that day. And billing is actually able to submit that day, unless, of course, on the backside, billing is needing to change code. And so that's a welcomed improvement in the workflow to all staff, because it's frustrating to the nurse to kind of badger the provider. They're wondering, well, why wasn't the patient referred to physical therapy? Well, you haven't finished your note.
Yeah.
And so it's a vicious cycle that I think oftentimes as clinicians don't really recognize kind of the downstream impact of not fulfilling the documentation in a timely manner.
Got it. And I can only imagine a note that's completed 2 weeks after a patient interaction, especially given how sick your kids are, how intensive, how much their condition evolves over time. I can only imagine like how bad those notes were and how much they missed in terms of being able to capture the narrative around that patient.
Right, right.
Yeah, interesting. And then one of the things we wanted to talk about is a little bit about your hardware. So you have an interesting situation there where you use hardware from a vendor. So you're not using necessarily your iPhones or Androids. Can you talk a little bit about that? How you think about hardware?
Yeah, we find that it's real critical that we're able to provide our team the tools that they need to be able to care for our patients, and access to those tools ultimately will determine the quality of care we provide. And we, as a facility, are accountable not only to the patient, but to the staff, as well as our community stakeholders. And so, therefore, for us to continue to provide exceptional care, we have to provide the tools to our staff. And so this isn't just the device, but also kind of back to our comment about ADA staff members, is making sure that they have the resources additionally. So, we began this process of evaluating, the laptop, that we have, that our providers use, as well as the iOS devices, iPad minis, as well as the Zebra handheld computer. And we've got a number of the Zebra handheld computers. We haven't deployed devices to all of the bedside staff at this point. But that looks to be the biggest or most valuable device, I would say, because of a lot of the integrated technologies such as the barcode reader, low light capabilities. So from our standpoint, it also, particularly the Zebra, can be paired with a wireless Bluetooth enabled lapel mic. that could be used for ambient AI, which could be quite useful, particularly in a unit where there's other patients and other individuals that are actually engaging with patients and families. And such a device could also be paired with appropriate software to be able to provide duress as well as staff two-way communication.
Interesting. So really an all-in-one kind of device there that pulls into a bunch of different things. Okay, interesting. And then let's think about the roadmap. So where, what are you thinking about over the next quarter, 2 quarters, 3 quarters, next year? What's the roadmap for product development?
Well, we're currently working um, with you all on the nursing ambient product, and the so that's kind of in the immediate future. But we also acknowledge the importance of being able to wrap up the information that is being generated in addition to the information that exists within the EHR and what exists external to the EHR, like on the Health Information Exchange, so that we can actually provide a an ecosystem of care that is all inclusive. All information is essential, but by the same or at the same time, you don't want to become inundated with data just for the sake of having data. So we've not been accused of being myopic. So we are very broad in our approach, I think, to the future. And while not fully realized, I think ambient AI becomes part of a larger solution, which is a multi-agent ecosystem providing contextual awareness, providing sentiment detection, continuous summarization, real-time decision support, and multimodal sensing, particularly for those individuals who may have ADA compliance needs. And so that's kind of a long trajectory, but it all has a root in quality information. And I think one of the things that Ambient AI has provided is it's giving our providers the quality information of the encounters, and it becomes kind of the keystone, I think, to what we use that information for on down the road. So I think a very good example would be having the ability for our pediatric neurologist who's confronted with a child who has intractable seizures. The parent doesn't really recall all of the different medicines that they've been on. The neurologist could simply write out a prompt, what are all of the seizure medicines this child has been on, and what were the reasons for their discontinuation? Oh, here is the answer, and here are the links. You can reference out to those. So what did this do? The neurologist did not have to go and spend days reviewing the record. Now they have the answer. It's actionable information. They can determine right now what it is they're going to do, and they don't have to be concerned as much about having to retry medications that had been used and the patient was failed on them, but instead are having access to information that they can then use to improve the quality of care they're able to provide. So I think that's a very common use case in our domain, if you will, the patients that we care for. So we've got very large goals for the use of AI in our facility, and acknowledge that there are guardrails that need to be around that. But we are very, very forward-looking, to be able to implement these to improve not only patient care, but also increase staff satisfaction and reduce burnout as well.
Sure, sure, and medical malpractice, and I mean there's so many potential benefits. Um,
Right.
one of the things you alluded to there is what we call or what we're building into our Patient 360 platform, which we rolled out not too long ago, and essentially imagine a platform that pulls in disparate information from the patient's records, so their notes, their labs, their imaging, and then allows you to do exactly what you're asking, right? Write a prompt that says, "Show me this patient's medication history," and that's one thing if you're dealing with ambulatory patients that you may see 3 times a year or something like that. But for a patient who's been in the hospital for 2 years, my goodness, I can only imagine like how hard a problem that is to solve. So we're
Right.
excited to get you guys that technology sooner than later. Another interesting sort of outcropping of that technology or an output of that technology is what we call pre-visit summaries. So
Mhm.
imagine, going in to see a patient and being able to see like at a glance, this is the patient, this is why they're here, this is what makes them special, this is what their needs are for today. And I think really allows the providers to be focused on that patient and maximize the time with that patient at that time. So I'm very excited about that.
Right. Well, and if I may, I'll geek out a little bit here. Since I have you, you may enjoy this as well.
I will, I'm sure.
Given the fact that the population we deal with is quite unique, with the complexity of their underlying medical conditions, one of the objectives that we've had is to train our own models with our patient data, um, create synthetic data that could kind of, in essence, expand our N for all of the different conditions, which a vast majority of these are rare, um, and therefore allowing this to be the basis of our prompt interaction. So while there could be multiple models used for various use cases, we do feel that that probably is the best approach for us, particularly when it comes down to clinical decision support that is needing to consider um, the trajectory of disease for a given patient. A very good example is a cerebral palsy research network. What they're doing is that they're collecting data around patients who have increased tone and decreased movement of their extremities and looking to see on down the road, obviously projecting, is that with the data, which of these kids actually fared better with medical management versus surgical management.
Hmm.
Something like this would be incredible to be able to tell the parent, your child has some really unique needs. However, we built out this model that can project with, a 98% accuracy whether or not surgery would be appropriate. And surgery is irreversible. So you want to know surgery is needed before you actually put them under the knife. So that's another kind of use case where being able to have the data, being able to have the model, and being able to train it and expand on that for the purposes of our population. And we don't necessarily see us as so unique that there aren't any other facilities. I think I mentioned to you before, Pediatric Complex Care Association. It's a group of about like 27 facilities that go from group homes to facilities very similar to us, and they care for the same population of kids. So having this specialized ecosystem of care that is not just here in Bethany, Oklahoma, but it's throughout the US. It's about targeting care for our population and not that 50-year-old Caucasian male who seems to consistently be the basis of models out there. And so we acknowledge that that's not necessarily the best approach for us, and therefore are kind of beginning to look at that work around training our own.
Got it. And I love, again, because you see so much of what you see is rare, ends are very, very small. This idea of being able to pull together all these other data sources, train models on them, I think is very exciting. And I think will unlock a lot of discoveries,
Yeah.
notably to operate or not to operate on that young cerebral palsy patient. So that's great. And then sort of in our last minute here, I have a vision for being a healthcare provider in the future that I always like to refer to as hands off, where you're not typing into the keyboard, you're just using your brain, you are talking to the machine's giving you answers. Do you think, how far away do you think that world is? Is that a world that we want? What's your vision on that?
I want it, and I see it in 2 years. Technology is just advancing so rapidly, and I think I don't know exactly who said this, but the provider that doesn't use AI will not be a provider much longer, and those that do AI, I believe, will enjoy their job. And so that in and of itself will not only help the patient, but it will increase the provider satisfaction. And this would be all disciplines across the board. So I do see that ambient becomes a much more pervasive component of our documentation, but more importantly, kind of that ever persistent counselor, that parent back there saying, are you really sure this is the right choice to make? It isn't that we're taking over healthcare, it's just that we're supporting the individual to have sufficient information to be able to make that decision that can impact that patient's outcome. And so I do see this being sooner rather than later.
Sounds good. 2 years. And I can believe that number. And the way I think about it is augmentation of human capability, allowing us to do more and to do better. And I know that so many people worry about replacement, and maybe that's at some point down the road, maybe we're all replaced by computers. But I think in the near term, the ability to recognize that we as human beings, as providers, as physicians have limitations, and that these technologies can help us overcome these limitations, I think is an interesting opportunity for the future.
Yeah. And the limitation here isn't just to able bodies like myself, but it could be a individual who is disabled. So it puts everybody on an equal playing field. So there isn't a disability that could prevent a clinician or other staff member to be able to achieve what it is their objective is for their professional career. So I think it just kind of levels the playing field.
All right, exciting. All right, well, that's it for today. And Dr. Brannan, I'd like to thank you very much for taking time out of your busy day. You're doing important work there at Bethany Children, so thank you for joining us today. And again, this is Dr. Jean-Luc Neptune. Thank you for joining us for the Prescribing the Future podcast. We're looking forward to more episodes in the future. Check out our YouTube channel for more, and please subscribe.